In the evaluations, we will be asking you about how many of your residents have been screened for dementia and depression and how you assess for delirium. Michaela will be staying on after with you to show you how to complete the evaluations about the session. ECHO. We want to remind everyone that this is an ECHO webinar, which means that this session serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As the ECHO model goes, all teach, all learn. So it will take all of you to create this community of learning. A little bit about our format. After a short lecture from our experts, we will share expertise from the rest of the team and then open the time up for case discussions. We invite you to share any geriatric cases. It may even be on a topic not related to the topic of today's lecture. We only ask that you keep it HIPAA compliant, case for discussion. That means please do not share patient's name, birthday, address, and so on. We learn best from our patients. They are our best teachers. Our interdisciplinary team is here as well, and we are all willing to teach and share our collective wisdom with you. Most of you already know me. I am Juanette Gaylord, president of ARCA, a Care Home Operator Association. We have Maribel Tan, president of Foster Family Homes Association, Danielle DeLonghi from Aloha Care, and Leila Ventar from United Healthcare. Our geriatrician, Dr. Ritabel Fernandez from University of Hawaii, is usually here, but will not be joining us today. We recently finished a 4-month series on medications. If you're interested in viewing any of those lectures, you can find them on our website. We cannot offer certificates of attendance for videos you have viewed, unfortunately. You must participate in our education live. We are now on a 4-month series on the mind. This month, we will be talking about managing delirium complications. Now it gives me great pleasure to introduce our speaker, Dr. Aida Wen. She is an associate professor, Department of Geriatric Medicine, John A. Burns School of Medicine, JABSOM, at the University of Hawaii. She is currently the lead for the Geriatric Workforce Enhancement Program and is also the program director of the Geriatric Medicine Fellowship Program. She is a strong advocate for improving geriatric and dementia care, striving to help patients and providers help seniors age as gracefully as possible. So let's all welcome Dr. Aida Wen.
Thank you. Thank you so much. Oh, you're always so generous with your introduction. I will share my screen. One sec. Here we go. Okay, see that, everybody? Okay, yeah, so today we're going to talk about managing delirium complications. Okay, well, let's see. Okay, so we're going to first start off with just a brief review of recognizing delirium. We'll talk about the most common causes, and then we're going to focus the rest of our time on how to manage delirium behaviors and how to manage and prevent consequences of delirium. Okay, so here's a common case scenario, and you've probably seen something like this in the past. Mrs. S is an 80-year-old woman who had a fall 3 weeks ago, which resulted in bleeding in her head. Fortunately, it wasn't very big, and the rest of her medical workup was fine. She seemed a little bit like not motivated and stuff. Everybody thought maybe she's a little bit depressed. So they started her on antidepressant about a week ago, since her fall, because she's not motivated and she was staying in bed a lot to rest. But in the last 2 days, she was overall sleepier than usual during the day and also more restless at night. And she was really having difficulty focusing enough to follow directions, and she had trouble making her needs known. What is going on here? Anybody have any thoughts? What's going on?
She may have a brain bleed.
Yeah, that's true. Check that for sure.
Stroke.
Maybe. Something's up, right? Something's different. Okay, well, let's see. This is the confusion assessment method, the CAM criteria, which we typically use in the emergency room, the hospital, nursing home, when we want to see if somebody has delirium. So delirium has 4 features, right? The first feature is it's acute. That means it happens a sudden onset and fluctuating. So it's a new behavior in the last 24 to 48 hours. There's some changes in her level of consciousness and attention and thinking, and that kind of fluctuates during your interaction. Like you're trying to talk to them and things are kind of up and down, right? The second really important feature is inattention. So they're very distracted. They can't follow you. They're having trouble keeping track of the conversation, can't follow directions really well. The third feature is psychosis. Now, psychosis has a few features under that. One is hallucinations, where they're seeing things that aren't there, that nobody else can see, and delusions, or also hearing things that nobody else can hear, right? And then delusions are paranoid beliefs, even when there's obviously not true, and then you show them evidence, they really, really believe that this is the case. They're thinking, oh, there is somebody trying to steal my things or whatever, right? And then another feature of psychosis is what we call disordered thinking. So confused, they're thinking you're her ex-husband or somebody else who they're not. The speech is rambling and going in all different directions. There's no logic. It's hard. It doesn't make too much sense. Or there's very, very little speech and very, very limited, 1-word answers, 3-word answers. That's kind of it, So there's something going on. The thinking's not quite right. So you might see psychosis, or you can see the other feature is consciousness or sleep-wake cycle. So they may be hypervigilant. So that means really restless and awake, might be awake all night, but during the day, they might be just really restless and agitated. Or that's the hyperactive delirium variant. And then there's something called hypoactive delirium, where they're like sleeping all day, sleeping all the time, day and night even, and they fall asleep when you talk to them, right? So if you're seeing things like this, feature 1 and feature 2 plus feature 3 or 4, any of these, then you got to think, there's I got to think about delirium. So I'm just going to go back here a little bit. Anybody see any clues for delirium? It's okay, you can just chime in or chat. Any clues?
Not following directions.
Yeah, not following directions.
Restless.
Restlessness, yeah. Sleepier than usual. Yeah. And something in the last 2 days, right? That's what we said.
Infection.
Huh?
They had infection like that.
Yeah, well, yeah, you're reading my mind. Okay, we'll move on to the next. Oh, not motivated, right? Okay, so yeah, you have to provide all of these observations and descriptions to the doctor, right? Oh, there's something sudden that happened. They're talking crazy talk. They can't follow directions. They got these random sleep-wake cycles. They're behaving kind of aggressively, or they're trying to harm people or themselves, something. Just describe these things to the doctor, and that will give them clues to be able to figure out if they have delirium, right? So these are finding the clues, which we just did. So very good. Yeah, we mentioned all of them, and I think she does have delirium, right? Now, so, again, I said, all caregivers should look for these early signs of of delirium, right? Seems different, talks less, needs more help, eating less, drinking less, all these kinds of things. I give you a hint, like, oh, something is up, right? And why does this matter? Because the top 3 causes of delirium are drugs, new medications, infection, like urinary infection or pneumonia, and labs. So something is wrong with the labs, like they're low sodium, high potassium, their thyroid is off or whatever, right? Calcium's off. And you need to get medical evaluation right away because something changed in the last 2 days. Somebody also mentioned maybe had a stroke. Maybe there's more, the head bleed has expanded more, and we really need to check, get another MRI, get another CAT scan, because there's something wrong, something changed. It could be even a silent heart attack, right? Or low oxygen, or even constipation. I've seen constipation. No, they had surgery and stuff, and then no BM for 1 week, right? And then all of a sudden they're kind of crazy. And then you disimpact them, and then all of a sudden their brain is back to normal. So all of these things, there are many causes of delirium, but if you see delirium, you got to think there's a medical problem, got to find out, got to talk to the doctor, right? So what
Yep.
happened here? Yeah, vital signs were all normal. He doesn't have constipation. She was sleepy, but arousable, answers with short phrases, responds slowly, doesn't open her eyes to neurochecks, like just keeps them all shut. You notice some skin breakdown on the buttocks due to moisture because she's been refusing to be changed. You did so the doctor got a head CT, good thing, to make sure no new stroke, no expanding blood, and checked on the labs, and her sodium is low, 130. We discovered something. What else? We discovered that she's dehydrated, elevated BUN creatinine. That indicates dehydration. Urine had some white cells and a little bit bacteria, but not a lot. So it doesn't really indicate a urine infection, right? So what does this delirium do to? Low sodium, dehydration, possibly from that new antidepressant, right? And maybe she's still got lingering effects of the head injury, because head injury in and of itself can cause delirium as well, right? So yeah, so those are the things that we can fix, kind of, right? So what do we do? So the treatment for delirium is to fix the underlying problem if we can. So we replace the sodium, give her salt, push fluids, fix the dehydration, and stop the antidepressant. So those are the things we can fix. What can we not fix? Her head injury, a little bleed in the brain. I think that will take time to resolve, right? The body will resorb it, but it's not gonna be next week. That's gonna take a long time, right? So that is gonna be slow recovery. But the things that we can fix, we can work on. So the problem is that so if we can fix those and she still has a little bit of tired and not motivated, that might be just hypoactive delirium, right? Hypoactive delirium, and she's still gonna not do stuff for you. So what do? We want her to kind of do rehab or cooperate with the treatment plan, but she's gonna still be having delirium for the long run. So we have to get her to cooperate somehow. So if the person has agitated delirium, where she's up all night, she's sleeping all day, it's very easy manage, right? But she's up all night and agitated and refusing to be changed at night and all that sort of stuff, then we have, a problem. So if we try to medicate her, what do you think will happen to her? She'll probably get more sedated, right? And then she really won't wake up for a few days, and that would kind of be worse, right? So I would say that if the behavior is not dangerous, maybe just tolerate it. If it's not dangerous, allow them to just respond to their environment and do whatever they're doing. Observe them, and you might get clues about what might be upsetting them. Or anticipate. If they can't tell you, try to think ahead to meet their needs, to avoid frustration or danger, right? So, and don't agitate. So if they don't want to do something, your reasoning with them is not necessarily going to help. And even reorienting them might make them mad. So just go with their flow, try distraction or humoring the patient, something like that. You can try to create safety. So just think about it. If you have delirium, you're kind of confused about your environment. You don't really know what's going on and everything is a little scary. So you have to create safety. So patient has an urgent need to feel safe. So be aware of your body language, speak slowly and calmly, show empathy, respect, and address your feelings, apologize, agree with them, and back off. And just try again later. Try to show some concern, right? I noticed you didn't eat breakfast this morning. You know what? That makes me worried that you might get dehydrated again, you know? Can I do anything to help you feel more comfortable? Listen and don't dismiss any of their concerns, even if you think they're delusional about it, right? Okay, you say, yeah, I could see why you're worried about that. I would be too if that was the case. Yeah, right? And personalize the care. Don't just do stuff to them, right? Do it with them. You know, use a favorite food or a drink. You know, if chocolate works, use chocolate, right? Use their favorite music, ask for permission. That goes a long way instead of demanding things. And redirect and consider music therapy or gentle sensory stimulation to keep them awake when they are falling asleep, right? Something like that. That way we can sort of keep them awake a little bit without during the day and so that they can sleep at night. So what about medications to manage delirium? Well, there's a lot of different meds that people use, and I'm sure you've seen many of these, right? Medicines to manage delirium and psychosis. Well, there's benzodiazepines, that class. There's stuff, Ativan. That sounds familiar to everybody. Well, basically, Ativan is a tranquilizer. It makes people sleep, right? So it doesn't fix any psychosis. It doesn't fix anything. All it does is help people sleep and can greatly increase the risk for confusion and falling. So that's something we really want to avoid as much as we can. In fact, sometimes what happens with Ativan is what we call kind of a rebound effect. So if you get them to sleep and they're real quiet, and then when the Ativan wears off, it bounces back at a higher level and they're more agitated than they were before. So yeah, benzos aren't really the greatest idea. So if we can try not to use them, that's the best, because you might get this rebound effect and you might get, you know, just more sleepiness and risk for falls and things like that. So also, not to mention that Ativan is benzodiazepines as class. They're kind of addictive as well. So we don't want to get people addicted. Antipsychotics are often used for psychosis when people are especially seeing things that aren't there, or having delusions. So these are the things, Haldol, have you heard of that? Seroquel, Zyprexa, Abilify. There's a new kid on the block, Nuplazid. But basically these block dopamine, and they can they help with delirium, and some of them are less sedating than others. But they do have some concerning side effects, which I'll talk to you about in the next slide. There's the serotonin reuptake inhibitors, which are actually the antidepressants, and there's a bunch of these. You've heard of Celexa and Lexapro. These are basically the serotonin, the antidepressants that we use. They have, as we talked about in our case, one of the main side effects is low sodium in older adults, and so I always be careful about that. And then there's anti-seizure medicines like lithium, and anticonvulsants like gabapentin or Lyrica or Depakote. Those are all in the class, right? There's the mood stable. So there's many types of medicines that the doctor may use, but really, and if they even prescribe it as needed, try not to use it if you can. And I'll talk a little bit about that. So here's some common problems with those antipsychotics. Common antipsychotic side effects is what we call metabolic syndrome. It causes people to develop diabetes. Their sugars get out of control. you can get high blood pressure, high cholesterol, and you gain weight. Starting people on this, and then 2 months later, all of a sudden their sugars are up and they're gaining weight. At first you're like, oh yeah, it's good they're gaining weight if they're underweight, but it's not a good weight to gain actually. And the black box warning is that this antipsychotic use is associated with heart attack, stroke, and death. So last resort, right? The other problem with antipsychotics is that they cause movement disorders. So what is a movement disorders? Remember I said it blocks dopamine? Well, so it makes people look like they have Parkinson's disease, right? Because that's a deficit of the dopamine. And so they may develop tremors like the Parkinson's, shuffling gait, and slow movements, or they could cause restlessness. It's called, fancy words, akathisia. And so they just can't sit still, and they're really, really fidgety. And they were anxious and restless in the first place. And you treat them with this antipsychotic, and then sometimes they get worse. You're like, oh, wait, what happened? Maybe it's this akathisia. Then there's dystonia, which is this involuntary painful muscle contraction. Anybody ever sleep with their head neck wrong, and then you wake up and your neck is stiff? Kind of like that. Your neck is twisted, it's contracted, it's painful, and you can't move it. Sometimes that happens with these medicines. And tardive dyskinesia is where you might see involuntary tongue thrusting, so meow, 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 like that, blinking, squirming and twisting, not voluntary. They're just doing it and they can't stop it. They can't help it. And their legs are moving. They're crossing and crossing their legs and moving it back and forth and up and down. And that's tardive dyskinesia. So yeah, if you use antipsychotics long-term, they may develop these movement disorders as well as the metabolic syndrome. So to medicate or not, antipsychotics and sedatives are only to be used as a last resort. So only if the patient is so distressed that they're going to hurt themselves or hurt others, or they're so distressed they can't sleep because they're really worried about this fire that's coming to get, or whatever, right? And they can't get off of that, and it's just driving them, not to sleep, right? Then yes, then you got to treat it because their quality of life is really bad, right? So that's when. Now, and of course, if the behaviors are dangerous, they're ripping things from the wall, and they're throwing furniture, and they're throwing dishes and water. Okay, if the behaviors are dangerous, call 911, but you should know that there are few or no geriatric psychiatry hospital beds in Hawaii. And so if they go to the hospital with 911, they're going to do the medical workup. They might give them a couple of drugs, and then they're going to send them back home to you because there's really no place else for them to go. So hospitalization and medications, they're the real short-term fixes, and it doesn't solve the problem. And ultimately, a change in the approach is still the most effective intervention. Okay, so the other thing that happened, so let's go back to our lady, Mrs. S. So she is home now. She's got this medicine for her UTI, but she's still very non-motivated and very sleepy and tired. What are some potential complications? Well, you know what? While they're having delirium, they may develop urinary incontinence. They may never have had it before. They may have always gone to the bathroom, but all of a sudden they develop this urinary incontinence because they don't know that they need to go to the bathroom, or they kind of a little bit confused. And so scheduled toileting program, right? What else? If you're delirious, then you may not have safety awareness, right? And maybe trying to get out of bed, and then everybody says, no, stay in bed, stop, go back, sit down, don't get up, right? Then they get weak, They have falls, right? And then on top of the delirium, all of a sudden you have a hip fracture, right? And so that compounds the problem. So, needing to think about it. Well, if we know that these people often have immobility and falls problem, then let's go mobilize with this. We'll go to them, help them, assist them, walk to the bathroom, assist them, go to here or there, and get them physical therapy in anticipation. Don't wait till they're weaker. Don't wait, right? Because by then, don't wait till they fall. Get somebody to sit with them and spend more time and walk them together so that we can prevent this. It was too late. She already developed a pressure ulcer because she was lying in her urinary incontinence, right, for like 2 days. That's all it took, 2 days. It doesn't take very long. But that's totally predictable, so because her brain wasn't working and she wasn't moving, had the hypoactive delirium. So what we need to do is anticipate it and mobilize, reposition her frequently, monitor all those pressure points, the back, the buttocks, the heels, right? All those areas, and make sure that she doesn't develop pressure sores with this. What else? Sleep disturbance. That's almost by definition with the delirium. So we have to, if we can have a sleep routine and avoid sedatives, that will help. And if you can use gentle sensory stimulation during the daytime to keep them awake, you don't have to be really annoying and, play, shake them up or anything like that. But, something gentle just to keep them a little bit awake would be helpful. Even like, you hold their hand and you do a little light massage on their hand and do some range of motion. Somebody is interacting with you. Your mind is slightly awake, right? Poor nutrition and hydration and aspiration. How many times have you seen this, right? Where just because they have a little urine infection and they're sleepier, they don't quite drink enough or they aspirate. Right. And so on top of the delirium, all of a sudden you got a pneumonia too, right? Or you have dehydration. So, or they lose weight. All of a sudden it's like, oh, when they had COVID, they lost like, 6 pounds in the last, month or something like that, right? So before waiting till that happens, start assisting with feeding. Use aspiration precautions, making sure they're upright when they're eating and double swallow and alternate solids and liquids, or, make sure you wait till everything is swallowed before the next. Take your time, add supplements, so just paying attention will prevent this weight loss, dehydration, aspiration. Okay, I'm just getting ahead of myself here. Okay, and then what else? We can also prevent functional decline. So families and caregivers can reinforce and restore function beyond PT and OT therapies, right? So as they're waking up and the delirium, the fog is clearing, we can start to reorient them a little bit to per time, place, person, if they aren't annoyed by you. If you're bugging them, then stop it. But if it's helpful, it feels like they're rejoining the real world. Monitor for depression. Sometimes when people get this way, they kind of get discouraged and depressed, and so make sure we implement behavioral activation, which is just schedule some pleasurable events. Get that granddaughter to come in and visit, send letters and phone calls and, have that birthday party or whatever it is. Schedule those pleasurable events, scatter them all over the place, put it in the calendar, right? And to try to stave off this depression thing, which is very common after a hospitalization or some kind of illness. Sometimes, and what about ADLs and IADLs? So they were performing at a certain level, and when they got delirious, of course, that went down and they needed more assistance. So definitely provide the assistance. But sometimes we forget and we continue to provide the assistance and we don't give them a chance to try it again. So let's back off a little bit. So let's slowly, if they're doing a little better, back off and see what they can do. And try to let them kind of get back to their previous baseline, right? Slowly over time, just, as the delirium reverses, try to adapt it to match their ability. Try again. So yeah, and then, but I do want to note that you have to prepare for the long haul, right? So delirium can be persistent. So in some cases, you may have seen when somebody gets delirious and they have a urine infection, you give them antibiotics, and you know what? In 7 days, they're back to their normal. They're back to their usual, and you're like, yay, she's back, right? Sometimes it takes a little bit longer, especially if they have some significant dementia as a baseline. It may take them 3 weeks to get back to normal. So, or if they've taken this medicine that's long acting, it may take some time to wash out of the system, right? So it may not be a week, it may be 3 weeks. And for some people, it may be 3 months. Especially say if she's had a head injury and she's got blood in her brain and she's got, and the blood's going to take some time to resorb, and it's not that quick of a fix. She may have this for a little bit longer, so maybe 3 months before delirium resolves. And unfortunately, for some very, very small percentage of people, it doesn't resolve. And this may be their new baseline. So I would say that we may need to provide ADL support for the long haul, and we may need to consider long-term support for IADLs and ADLs. So it's always good to prepare families for this. I always say that. I always tell them that, this is the risk, and we're going to provide the assistance as much as we can. They may not get back to their baseline. Most do, but some don't, and we just want to be prepared. We hope that's not the case, but we're gonna support as much as possible her potential for recovery. And then, so in summary, early recognition of delirium is important because if it's a medical emergency and a medical problem, we have to treat it. And the most important and most common causes of delirium are medications, infections, and chemical imbalance. A calm and reassuring approach is the best approach. And as I showed in those 2 tables, you can anticipate and help manage and prevent potential complications of delirium. And you can also move towards restoring function. And so being mindful of those things are really helpful to support our residents and help them recover as much as possible beyond just, the medical cure from the doctor. So with that, I am gonna open it up for case discussions and see if people have seen something like this and what they think. See if they've had some tricks and tips that they've had or some questions or concerns.
I think delirium is prevalent in the community as a whole. If you have any dementia residents, I mean, at some point in time, they are going to be delirious, so be it an infection or a fall that might cause a brain bleed or a stroke. So we have a lot of those things. I mean, anything can happen at any time.
Mm-hmm. Yeah, which is why we have to be on the lookout. Anybody got some good stories? You can type it in the chat box or just unmute and speak up. We love to hear your voices if you have a story to share or ideas or things that you've tried. It does take a lot of patience, though. But I really love seeing when they actually slowly recover and get back to their previous baseline.
So Dr. Wen, we do have a question in the chat box.
Oh, yes.
Yes, it says, oh, shootsies. Can delirium occur in adolescence?
Oh, you know something? You know, I only talked about delirium caused by, well, delirium is caused by what we talked about. However, when you're saying, maybe I think you're referring to psychosis. So psychosis is when, you know, like I said, disordered thinking and maybe hallucinations and maybe acute changes like that. Sometimes that can happen with drug use, or, you know, alcohol, those kinds of things. So that can cause these psychotic episodes. Other things that cause psychotic episodes are things like mental illness, like schizophrenia or bipolar disorder, which oftentimes can present themselves in the teen years, things like that. So so if there's some paranoia going on, right, then you need to rule out mental illness and drugs and alcohol and fever. Yes, high fevers, right? Have you ever seen the temperatures that go to 103, 104, and then your brain's not working? I actually had that happen when I had a high fever when I was a kid. It was really scary. I was seeing weird dreams and all kinds of things like that, right? Those things can happen, yes. So things like that, true. But then yeah, usually have the delirium has a you have to sort of fulfill all four features that I showed you earlier, right? Where it's acute, sudden, it has those brain psychosis going on, and it has that sleep-wake cycle that's kind of messed up, and it has trouble concentrating. And that's the definition of delirium, where you prompt to look for a underlying medical illness. And once that medical illness is resolved, then you've got to look for other reasons. A very common reason in older adults is dementia, underlying dementia, and things like that. So, but don't rule out, yeah, don't forget there's mental health problems too. Oh, here's a question. I have a patient that I cannot give Lexapro at night because she always thinks this is a sleeping pill. And that's why she doesn't want to take it at night. So I give it in the morning. But the problem is she's sleepy in the daytime. Yeah. So talk to the doctor about it. There are other antidepressants that the side effect is sleepiness, but other antidepressants have side effects that cause them to be more awake and more stimulating, and it should be given in the daytime. So maybe work with the doctor and find a different antidepressant that she could take at a different time of the day.
Another question is what's the difference between delirious and being paranoid?
Okay, so I'm gonna go back to my, oops, sorry. Can I go back to my screen here? Oh. Okay, can you see that? Yeah. Okay, I'm gonna go back to this one. Okay, so the paranoid is here where you're paranoid beliefs, where you're having delusions. It's psychosis. So some people have psychosis and paranoia, but it's not acute. It didn't happen in the last 20 4 to 48 hours. This is a chronic problem. They have this, it's been going on for weeks and months, right? Or they're not falling asleep when you talk to them, and they're not having trouble focusing, right? Or something like that. So then they only have psychosis, they only have this paranoia, but not any of the others. If they have this whole constellation of other features, then I would say delirium. But it has only a subset of that, and that's psychosis and paranoia. Then I would think more like mental illness or things like that. So that's the difference. Does that help?
So, Dr. Wen, this is Mary Val. What would be the um, factors that may have caused hallucinations or all the psychosis behaviors, and how to deal with them? What type of approaches that you would do? Because one of the things that I was told, since there is no actual behavior plan, is to redirect. But if you are not knowledgeable on all those different redirection techniques, where do you go from there?
Well, I think you need to get, I guess, education, and practice. It's really an approach on how to help patients feel their behaviors are due to their inability to understand the situation and communicate, and so they're scared, and so that's why they're having the behaviors and not cooperating. And so if you understand that, then we have to think about, so what kind of approach will help somebody who's scared and not cooperating? One way, so that's why I think about, how would you talk to a toddler, right? Say, well, okay, let's get down to their level and smile and nod and agree with everything and say, yeah, I understand. Yeah, this is kind of hard. Yeah, I would feel that way too, and acknowledge their feelings, and then try to see, well, I wish it was different. Let's see if we can make the best of this situation. Can we try this together? Let's do this together, one step at a time. Don't overwhelm them. Oh, thank you so much. Can you help me? Those types of phrases can go a long way. And some people are actually, if you notice, right? Like there's some people who are really good with kids, and some people are really good with special needs kids, right? It takes just a little kind of practice. Some people are naturally good at it. Some people take practice. And so this is what I kind of say. It's kind of like learning to speak dementia. It's not really a language, but it's a way of communicating to somebody with dementia and dementia who doesn't understand and having behavior. So the approach where you're kind of calm and understanding and addressing their emotions and partnering with them can really go a long way. And there's some people who are better at it than others, and sometimes it's not even your fault. Some like some residents, they like male caregivers instead of female ones, right? Or the vice versa. And maybe you look like somebody, maybe you look like their niece, nothing to do with anything you said. Just because you look like their niece, they like you or they don't like you, right? So you sort of have to figure that out, and it takes a lot of creativity to have those types of approaches. So it takes some practice, and that's why it's great to have a forum like this, because then somebody else can share, say, you know what, I had that situation, and you know what I did this and it worked, right? Or something like that. So it's good to get tips from other people, especially when you run out of ideas.
Yeah, it's like in what my experiencing at the with my current clients, one client is that there is dementia, of course, there's hallucination, and doesn't seem to, it's like when I'm speaking to that client, it appears that I'm in that hallucination. Therefore, that client will respond inappropriately as if I'm part of that.
Mm.
So it's difficult to do a redirection on that behavior when knowing that you're part of that hallucination at that point.
Yeah. Sometimes if you just take a step back and give them space and try again later, or get somebody else to step in.
That's true. But when it comes to asking to do a task, or like just simple going to the bathroom, or going for a walk, or going to medical appointments, or just simply just taking a shower, it's like it's all approaches are ineffective because I'm not there, I'm not real.
Mm-hmm.
So all attempts of interaction to try and get my objectives completed for that day, it's just
Yeah.
went out the door.
Yeah, so sometimes medication is needed, if they're having too much psychosis, and they're having internal stimuli, they're responding to something going on in their head,
Yes.
not what you're doing, but they're responding to just something going in their head. They may need medications, so, and hopefully, we can get a small dose going, that might help. So small doses of maybe antidepressants before going on to antipsychotics, or small doses of antipsychotics, and hopefully trying to see if we can develop some trust, and that before we try to taper the medicine.
Yeah, I just saw the question. It says, are they having some flashback? Yes, definitely. It is.
So yeah, another risk factor for psychosis is PTSD.
Correct. I think definitely
So look for
that's
that
what I'm
history.
observing. Yeah. That's definitely what I'm observing.
Yeah.
But
So
there
when
is
you
no
do
actual
intake, right? When you do intake, you should ask about history of mental illness, history of depression, history of schizophrenia, history of bipolar, history of
none, doctor.
Yeah, there are
None.
treatments for PTSD. Yeah.
None. And that's the reason why my work is sometimes is questioned by the family, because some tasks are not done. Like, oh, did he take a shower today, or stuff like that. So then all you can do, yes, document, but how long? It's come to a point where it's like, when you remind the client and say, hey, you haven't taken a shower for a month, or you haven't taken a shower for 6 months. It's like,
yeah.
Yeah, we're onto that, where, see, it's also mixed with dementia. So I'm in a tough situation.
Yeah. Yeah, that's right. Yeah, so Renata is right. There is a clonidine, right, that helps with nightmares from PTSD, and there are some people are taking quetiapine. It makes people sleepy at night and also helps with the psychosis. So if you do your medicine, you have to try to get away with the smallest dose possible, and then increase it if you need to. Yeah. if you have to take it, I would target it for a specific time or specific, when the problem is the most, when it is the most problematic. So yeah, try to avoid taking these drugs for a very long time because like I
Yeah,
said,
that-
you have
that's
those side
true.
effects.
There is also one problem with that, those medication that I'm seeing is that it ramps up their appetite. So
Yeah.
and not when I'm trying to make them lose weight.
Yeah.
So it's kind of not a win-win situation. So that's my whole dilemma with one of my clients.
Okay. Yes. Yeah. Clonidine, also prazosin too. They are both blood pressure medicine. They seem to help with that. But yeah, prazosin is very commonly used for folks with that. Yeah.
Mhm. So do you think we because I know I don't want to sound redundant, but I work with behavior children before, so I am a behavior therapist way before this
Okay.
job, and all the tricks in the under my sleeve is gone off the window on this particular client. So I'm
Yeah.
just exhausted with all the different approaches. So maybe a fresh new approach that I guess basically that's what I'm looking for.
Yeah. Yeah. I hear you. You have to get pretty creative, I have to say. I said sometimes these dementia caregivers are the most creative people I've seen. They come up with all kinds of things. So yeah.
Yeah, I work with ODD and bipolar and
Yeah.
people,
Well,
autistic.
you can probably give everybody else here tips.
Oh gosh.
Yeah. It sounds like you're the pro.
Well, there has to be a behavior plan, so that way if one way doesn't work, then you do a different things. But right now there isn't even a diagnosis per se.
Yeah, and like I said, sometimes you really don't have a choice. And for quality of life for the person, and
Actually,
you
that's
have
what
to
they
use
want.
medicine. I
Mhm.
have definitely cases where we have to have them on medicines and we can't take it off because that's the
Yeah.
only way for them to enjoy themselves or have some reasonable quality of life,
Yeah. Well, there's only one episode yet where the client got aggressive, so physically aggressive with me. So just kind of keeping my distance.
Yeah, yeah. Well, God bless you for
Gosh.
staying with it, for staying with
Mm.
it. It's not for the faint of heart, for sure.
So when you do have maybe try to incorporate a behavioral different topics on different approaches to deal with different behaviors, I'm all for that, doctor.
Yeah, that's always
Looking for some answers.
yeah. Yeah. Sometimes like joining a support group like Alzheimer's Association or something like that, when you talk to other caregivers, you all exchange oh yeah, what worked, what didn't work, um,
Yeah,
share ideas.
yeah. Well, thank you so much, doctor, for letting me share.
Oh yes, of course. Okay. All right. Any other comments? Otherwise, I'm gonna let folks talk about evaluation, I guess, and I'll just stay on though, in case people come up with new questions to type in. Is somebody gonna
Michaela, did you want me to go ahead and read the questions?
Yeah, I suppose so.
Okay, so basically starting this month, we're gonna share with our team. Dementia and depression. So number one, how many of your residents have been screened for dementia or related disorders in the last year? So we want to know how many were screened and the total amount. Number two, how many of your residents have been screened for depression in the last year? Again, the number of screened out of the total amount. Number three is delirium. What tool do you use to screen for delirium? The UB-CAM, the CAM, or other? So that's basically those only 3 questions. John only had the 3, correct?
Yes, that's correct. So as a reminder, evaluations are required for certificates of attendance. Everyone that has listened to this lecture and wants a certificate has to fill out their own evaluation. As soon as you're done completing the evaluation and you hit that submit button, an email is going to be sent to you with your certificate of attendance. So I can stay on for a few minutes after this and continue to enter the link. I just placed it inside the chat box. I'll stay on and continue to enter it and answer any questions that people have so that we can make sure that everybody gets one of those. And then for anybody that's looking for a certificate of medical education, if you're an RN or MD, you complete an evaluation as well. Just select the CME option. And at the end of the year in December, you'll get a CME report from Queens.
Thank you, Michaela.
Thank you, everybody, for joining us today. Maribel, do you have anything you'd like to say before we wrap up?
No, Michaela. I just want to thank everyone for joining us today. And we'll see you all again next month for another great topic. Thank you, Dr. Wen, for that great topic. We learn a lot because that's very common to all our clients, our residents. Again, thank you, everyone. See you again next month.
Thank you, everyone.